Welcome to Newcastle Family History Society podcasts. The Newcastle Family History Society, located on Awabakal land in Newcastle, New South Wales, Australia, provides support for those interested in family history. Today, we delve into the remarkable story behind the creation of the Calvary Mater Newcastle Palliative Care Service. Imagine this, a doctor and a nurse, driven by compassion and sheer determination, starting a service with no funding, no formal training, and only a shared vision of compassionate care and a commitment to provide dignity to the dying. This is a story of vision, resilience, and innovation. It's a journey that transformed palliative care in Newcastle and beyond, proving what is possible when dedication meets necessity. Let's explore how Dr. Pamela Harrison OAM and Sister Mary Brendan O'Connor turned a vision into a legacy of care.
The creation of the Palliative Care Service in 1983 at the Newcastle Mater Misericordiae Hospital was unique, according to Dame Cicely Saunders, the world pioneer of hospice and palliative care and founder of St Christopher's Hospice, when I met her in London in 1986, and she showed her approval with applause. New services normally start with forward planning, funding and trained staff. In contrast, on the 24th of August 1983, two women, myself and a nurse, Sister Mary Brendan O'Connor, started a palliative care service with no planning, no training, no equipment, no funds, no support team, and only a mud map to guide us. The mud map was a copy of the symptom control notes from Naringa Hospital in Sydney, combined with the knowledge gleaned from a seminar I had attended 10 days before and my own research. We developed and staffed the Newcastle Mater Misericordiae Hospital Palliative Care Service 24/7 in a voluntary capacity until it was fully funded more than 3 years later. Now, after more than 40 years, and known as the Calvary Mater Newcastle Palliative Care Service, it is the greatest provider of services in Newcastle and the Hunter, New England health area. During the 1980s, the people of the Hunter campaigned for the government to establish oncology and radiotherapy services in the Hunter, as at that time visiting specialists from Sydney provided those services, and all patients needing radiotherapy had to travel to Sydney for their treatment. I was the sole haematologist at the Mater and introduced the care and treatment of patients with blood diseases, including lymphomas. I was on 3 committees: the Hunter Valley Oncology Group, which was successful in having the Mater as the designated site for oncology and radiotherapy; the Hospice for the Hunter Feasibility Committee, composed of professional and lay people concerned with promoting education in the care of the dying; and the Hunter Valley Cancer Appeal Committee, a group of dedicated lay people who raised thousands of dollars to help cancer sufferers in the Hunter. My job was to liaise with the 3 groups to keep them informed of developments, and consequently I saw an advertisement for a symposium on palliative care to be held at Lura in August 1983. The guest speaker, Professor Balfour Mount from Montreal, was responsible for introducing the term palliative care. At that time there was no funding and hardly any knowledge of palliative care in the Hunter region. I attended the conference and felt encouraged by the messages given as they reflected my own feelings and actions in caring for my patients. However, I realised that there was a lot more to be offered, particularly in pain control and options of being in hospital or at home. A few days later, Dr. Laird, who had worked in palliative care services overseas, gave a talk at the Mater that included a reference to the service at St Thomas's Hospital in London. This appealed to me as a model which would suit the Mater, and I resolved that if another of my patients asked to go home to die, I would try to make it happen. A couple of days later, one of my patients with a terminal disease did ask to go home to die. I had to act quickly and find a nurse to work with me and get permission to care for him at home. Sister Mary Tarsisius Ryan, the sister administrator, had provided me with a Sister of Mercy nurse to help me when I set up the Hunter Haemophilia Treatment Centre, now Calvary Mater Newcastle Haemophilia Centre, at the Mater. So I decided to seek help from her again. As the position of medical superintendent was vacant, I went directly to Sister Tarsisius and explained my plan. She told me to talk with Sister Mary DeLillis Connor, the matron, and the last of her order to hold the office. Sister DeLillis told me that as it was an outreach service, she did not need to be involved. I returned with the news to Sister Tarsisius, who gave her approval and support. Providentially, Sister Mary Brendan O'Connor was waiting assignment at the hospital, having recently returned from the mission field. She was an experienced nurse and was prepared to work with me in palliative care, with both of us providing a 24/7 commitment. As sole haematologist, I was already on unpaid 24/7 call, nevertheless prepared to volunteer my time in palliative care in addition to my full-time employment. We were responsible directly to Sister Tarsisius. My patient's wife was prepared to care for her husband at home. At that time, dying patients were admitted to hospital, so I telephoned his general practitioner to tell him his patient wanted to go home to die. I explained the support we would provide and we would like to work with him in caring for the patient. He agreed. So on 24th of August 1983, 10 days after my return from Lura, we had our first patient. I knew he would need oxygen at home, but had to convince the specialist that it was not appropriate for my patient to attend the respiratory clinic to see if he met the criteria to receive the oxygen, especially as he would be deteriorating daily. Permission was eventually given on a one-off basis for further discussion. We had expected Sister Brendan to be involved in symptom control and out-of-hours support, with community services providing nursing care and equipment. Instead, we found all services were geared for the chronically ill, and there was a waiting time greater than our patient's life expectancy. So we had to improvise. Sister Brendan borrowed the social worker's car during the day and the convent car at night and met the patient's nursing needs as well as providing palliative care. Equipment was borrowed from the hospital's pool, which had been donated to the social work department by the Hunter Valley Cancer Appeal Committee. The patient died at home 5 days later. All his needs were provided for, and Sister Brendan also attended the funeral. This experience with our first patient alerted us to the difficulties in carrying on the service, but with oncology developing at the Mater, we both wanted to continue. So we did. We called it the Newcastle Mater Misericordiae Hospital Palliative Care Service. I applied and received official recognition of the service from the medical and hospital boards, and I was appointed as director in a voluntary capacity. Sister Tarsisius arranged a series of meetings for the Mater staff and the community nursing services and hospitals so I could explain the function of the palliative care service and the fact that we wanted to work with other services, not replace them. Later, she arranged for Mary Ann Kelty and Helen Elsley to be employed as relief nurses, allowing Sister Brendan to have a holiday and a week's retreat. Referrals started to come from the oncologist and other specialists in the hospital, and later GPs were the main referrers. Sister Brendan and I met each afternoon to discuss the patients, and I was available 24/7 for advice and to visit the patient at home. I cared for patients in the hospital, including those who could not be sent home, and others who were admitted for symptom control or for their terminal phase, as this was always an option if the family could not cope. Pain has always been a major fear for cancer patients, and I now knew that the information taught to medical students was obsolete and inappropriate, and pain could be controlled by matching the medication with the pain. I introduced giving morphine by mouth instead of by injection, which was unknown in the Hunter region at that time. Local chemists did not stock the medicine, so the hospital pharmacy made it up for us, as tablets were not available then. Sister Brendan trained the patients and carers in its use, contacting me as needed. We continued to improvise. I did not contact the respiratory physician again. Sister Brendan used oxygen cylinders from the hospital, and I provided my luggage trolley to transport them. We did not have flotation mattresses to prevent bed sores, so we used blow-up rubber lilos, the mattresses used for camping, using water instead of air. When a bed was needed, a disassembled hospital brass bed would be loaded into the station wagon by the wardsman, and Sister Brendan would assemble it in the patient's home. The Mater did not have an occupational therapist on the staff then, so I arranged for the OT from geriatric domiciliary care to meet with us, and she introduced Sister Brendan to bath boards and shower hoses. So she added another spanner to her nursing kit. Mobile phones were not available then. Sister Brendan had a long-range pager, and when it beeped, she had to ring the hospital switchboard to receive the message. She claimed she could always rely on the red phone in the nearest hotel if the public phone box was vandalised. The Cancer Appeal Committee donated items needed in the home, including proper flotation mattresses. In December 1983, together with the Hunter Nurserymen's Association and Young and Green, they donated an automatic Holden Chimera station wagon, with air conditioning donated by Mrs. Jane Durbin. Sister Brendan now had reliable transport, which also doubled as her office for 14 months. When we began to receive donations from the public, service clubs and others, Sister Tarcisius set up a trust fund for the palliative care service, and in 1985 we were also donated oxygen concentrators and subcutaneous infusion pumps, which improved patient care at home. With still no funding for staff, I met with Margot Thompson of the Hunter Volunteer Development Centre, and she ran the first palliative care volunteer course in the Hunter for us, starting in February 1984. The Professor of Psychiatry, Beverly Raffel, who specialised in bereavement, was based at the Mater, and she assisted with the course. Another course was held in 1986. Sister Brendan matched the volunteers with patients in need of their help, and one, a Mercy sister who had been a music teacher, played the violin to my patients in hospital. I worked on submissions to the Department of Health for support for staffing and plans for a regional service, including a joint submission from the Mater Palliative Care Service with the Hunter Palliative Care Association and Make Today Count, submitted in January 1985. There were some results. In 1984, a community nurse coordinator, Mrs. Dawn Emerton, was appointed on 12 months federal funding. She visited the hospitals and community nurses in the Hunter area and organised education programs. She asked to relieve Sister Brendan one day a week and volunteered her time to relieve her that night as well, so Sister Brendan had a weekly break. The first funded palliative care nurse to join our team, Mrs. Robin Hertz, was appointed in 1985. Her nursing skills and personality allowed an easy integration into our team of two. It also meant that a room for an office was allocated for the palliative care nurses in the Macaulay Centre. Dawn's successor, Mrs. Danny Jenkins, was appointed Community Nurse Coordinator in 1985 on permanent Hunter Region Health funding, now without involvement in hands-on care. I was invited to give lectures on symptom control in the Hunter region and from Long Jetty to Port Macquarie. The University of Newcastle was one of the first universities in New South Wales to introduce palliative care into their medical curriculum, and I gave the first lectures to the fourth-year medical students in April 1985. By September 1985, the majority of our referrals were coming from GPs. We could not cope with the workload and had to reduce our area service to a 10-kilometre radius and introduce a waiting list. This had an unexpected response. The hospital was contacted by Dr. Owen James, the CEO of Hunter Region Department of Health, as he was receiving calls from GPs with patients on our waiting list asking why we were so understaffed. Soon after this, Dr. James set up a working party for the development of palliative care in the Hunter, which eventually resulted in the funding of the service by the end of 1986. Another palliative care nurse, Philomena Jabor, was funded in March 1986, followed later by two more, Judy Fisher and Louise Hannaway. Other nurses were rotated through, including Stacey Greentree, Catherine Bowe, Anne Smith, Monica Keogh, and Lud Miller or Millie Sneesby. So night duty and holiday relief were covered. In January 1986, the medical superintendent unexpectedly appointed as visiting medical officers in palliative care 5 GPs, Doctors M. Braggett, H. Rose, I. Walker, J. Dickinson, who was lecturer in community medicine, and A. Reid, Associate Professor in Community Medicine. This created difficulties initially. They had no prior experience in palliative care. However, we worked out a system to educate and integrate them into the team. Thus, while my voluntary workload increased, the future viability of the service was facilitated. I was beginning to get calls for help from doctors and hospitals in the Hunter region and Mid-North Coast. Palliative care had come to stay. By the end of 1986, the Mater Palliative Care Service was fully funded and viable without the need of the voluntary involvement of Sister Brendan and myself. The outreach had cared for 255 patients, 220 of whom had died. Nearly 50% had died at home, compared to the Hunter average for home deaths of 17.5%. Most of those who died in hospital were there for a short time and were under my care, as were others who could not be discharged to the outreach. The service continued to grow, and in 1993 the Mercy Hospice was opened. In her opening address, Sister Monica Sinclair, the Congregational Superior, acknowledged, and I quote, "The hospice was the culmination of an initiative that began with just two, Dr. Pam Harrison and Sister Mary Brendan, as a palliative care outreach team in 1983." End of quote. After ownership was transferred to the Little Company of Mary Healthcare in 2006, the Newcastle Mater Misericordiae Hospital was renamed Calvary Mater Newcastle in 2007 and retained its public hospital status. Now, more than 40 years after its conception, the Calvary Mater Newcastle Palliative Care Service provides outreach care to the Newcastle local government area and portion of Lake Macquarie, with consultative services to the Hunter New England Local Health District. It receives about 140 referrals a month, and up to 500 patients use the service at any one time. Approximately 90 people are employed, including the staff of the 17-bed hospice. There are 9 doctors, over 50 nurses, 1 physiotherapist, 2 social workers, 4 occupational therapists with 2 auxiliary staff, 2 pharmacists, 1 senior research fellow, and 10 administrative staff. Volunteers continue to contribute to the service. I was able to create the unfunded palliative care service because of the unique composition of the management at the Mater at that time and the availability of Sister Mary Brendan O'Connor. We were free to adapt to local conditions and could work as a team, responding to need without the hierarchical boundaries which came later. There was respect, confidence, listening, humour and support for each other and for patients and carers. Sister Brendan was pivotal to the success of the outreach, and she fulfilled her role admirably. We were both prepared to volunteer our time 24/7 and worked with perseverance and determination to bring support to the terminally ill. My multiple submissions for funding and plans for our service and regional development met with little response. Ironically, it seems it was the success of the service and our inability to meet the growing need that drew attention. Concerned GPs contacting the Hunter Region Department of Health in 1985 seem to have been the stimulus for the authorised planning, and funding was achieved by the end of 1986. After nearly 3.5 years, the Newcastle Mater Misericordiae Hospital Palliative Care Service was viable. We achieved our goal. Our reward is the survival and success of the service.
The story of the Calvary Mater Newcastle Palliative Care Service reminds us that even the smallest beginnings can lead to monumental change. The dedicated efforts of Dr. Pamela Harrison and Sister Mary Brendan O'Connor have built a foundation that has grown into a cornerstone of the region's healthcare system, and their legacy continues to impact countless lives with both compassion and dignity. Thank you, Pam, for sharing your stories with us and for the remarkable contribution you have made to medicine during your long career. If you'd like to know more about the Mater's palliative care services, a quick online search will lead you to their website. You've been listening to Newcastle Family History Society podcast.